Hi, welcome back to Season 4 of the Tummy Team Journey. I am Kelly Dean, physical therapist and founder of the Tummy Team, and I'm your host. This is the podcast where we talk about how investing in your functional core and pelvic floor strength can actually change your life. So let's get started. Hi, everybody. Welcome back to the Tummy Team Journey podcast. I'm Kelly Dean. I am the founder of the Tummy Team and your host. And I have a unique client guest today. I was going to say client because it's not a client, not necessarily. So one of the things that you may or may not know about me is not only I'm a physical therapist and I run the Tummy Team and I do all those online courses and I do this podcast, but I also am a teacher. I'm an instructor and I teach continuing ed courses. And one of the continuing ed courses that I teach is functional core and pelvic floor for seniors. And I teach it to an organization that has a ton of skilled nursing facilities and PTs and OTs and other rehab assistants that work with seniors. And I teach this course, and our guest today is Mary Mello, and she's an OT who has gone to two of the courses that I've taught for seniors and is using this work in her own life and in her client's life and has really taken um, a real joy in this work and has some really cool things to offer. So I wanted to have you on today, Mary, so we can just talk all things core and pelvic floor with seniors and beyond. So thank you for joining me and welcome.
Thank you, Kelly. It's always a pleasure to talk with you. And as you know, I love what you do, and I love implementing into my work. So
Yeah.
it's great.
It's been really fun to watch. We were just talking a little bit before we started recording, just to watch how by my ability to teach other therapists to do this work really multiplies my reach and allows so many more people to get this information, which I'm super passionate about, and you are too. I love to work with other passionate people. So let's just start with letting the audience know a little bit about you personally, professionally. Just give them a little bit of background about yourself.
Sure. So I'm a native Californian, I should say. I'm the mother of two grown children, and I have two fabulous little grandkids. I've been married to the same gentleman for 30 years, and he's just a wonderful, wonderful husband. And I have a cute little dog he just turned 17. So he's an old guy. Yeah, he's an old guy. I'm also one of my other passions is my faith. That every morning I do my devotional and I spend my time in the word, and it just really gets my day started. I'm a very crafty and creative person. I can find 101 uses for something, and so my husband always makes sure that I don't have too much stuff laying around. But that really helps me in my OT field too, of being creative and having those creative outlets. I have been an occupational therapist for 35 years. I have my bachelor's of science in OT and a master's in gerontology. I've worked in a variety of settings, from acute care to pediatrics to post-acute stroke center to neuro rehab, but my passion is definitely post-acute care. I've been in post-acute care for over 20 years, and I just find that just the person who I am, and I love seeing my patients make the functional gains that they can in a post-acute setting, and it's just a really, really wonderful place for me to work.
Yeah. Well, I love that. Some people, and I know you get this a lot, some people might not understand what an occupational therapist is.
Yes.
So, do you have a little spiel that can educate people on what occupational therapy does?
I would love to. So my patients often say is that, we divide the body in half. Of the OT takes the upper body and the PT takes the lower body. It's like, well, not quite.
Not
um,
really.
not really, right? That's kind of one of their things. Or they often say, I don't have an occupation, I don't need you. And that's where I come in and say, oh, but you do have many occupations. And so activities of daily living, such as bathing, dressing, toileting, transferring, getting in and out of bed, being able to make a meal, being able to plan to make a meal, being able to walk from your bed to the bathroom, stand in front of the toilet, pull your pants down, clean yourself, pull your pants up. That's all part of OT. You need to be able to do that skill in order to return home, or you need to be able to have your pants on in order to walk down the hallway with PT. So
Right.
that's really important too, right? To fine motor, to some of the cognition that we do. I do a lot of postural sitting alignment and wheelchair assessment. That's a big core thing too, is making sure that the patient is sitting properly in their wheelchair so they can function through the day.
Yeah. Well, I think that one of the things that people don't think about is maybe the word occupation throws people off because they
Yes.
think about a job, right?
Hmm.
Um, and instead, I think about what are the roles of this person in their life,
Right.
as a spouse, as a parent, as just their own identity, like being able to do their own self care, being able to live in the world they live in, whatever that is. So it looks different for like a child who has to interact in school and around its peers, and it's different for like a young adult, and it's different for a senior, and it's different for somebody that is coming out of maybe some kind of decline that hospitalized them, and trying to get back to real life stuff.
Right.
And
Right.
a lot of people, when part of I have two businesses, one the tummy team and the other one is called Real Life Rehab. And Real Life Rehab is kind of my umbrella over all of the teaching and stuff that I do. But I often, when I'm teaching classes to PTs and OTs, so many times the OTs come up and they're like, it's like you're an OT.
Yeah. Right. Sure.
Because my passion is very much functional integration, and looking at how we make everything that we do, every exercise we do has a role to be functional, and quality of life, and kind of the big picture, not just their legs, but them being able to walk and reach and do the things that make them happy in their life. And so when I teach the courses that I teach for you guys, it is looking at people as a whole person,
Right.
and we come at it differently from our professional training, but we're still all looking at the whole person, and what does this person need to get back. And one of these big things that I teach, and that I think was overlooked when I was in PT school and looking at working with seniors, is the role of the core and pelvic floor muscles and the structure of those muscles for everything we have to do in life. And you mentioned a handful of those things just in your like OT kind of example, is like being able to sit up, being able to use the toilet, being able to balance to put your pants on, being able to, you know, reach, walk, brush your hair, brush your teeth. Your core is involved in so many things. And as we go through life, our core and our pelvic floor becomes weaker and deconditioned because of neglect, um, because of posture and all kinds of other things that happen in our life. And so, one of the things that we go over is how can we get that back?
Right.
And so, yeah. So anyway, we'll come back to that. But what was your first exposure to the tummy team?
My first exposure was, boy, that was in spring of 2023. The company that I work for, Enzyme Services, they do a lot of continuing ed, and the functional core and pelvic floor was one of the courses they were offering. And I said, oh my gosh, I need to take that course. And so that was, yeah, about 2 years ago now. And so it was the minute you started talking, it's like, oh my gosh, this is so, I can implement this so much into my OT practice. And I was hooked.
Yeah.
Actually, the day I got back, one of my first patients was a Parkinson's patient. And I'm like, oh, I can, everything I just learned this weekend, I can use with this patient. And
Yeah.
it was, and I've been doing it ever since. So yes, so that was a wonderful, wonderful weekend. And it just, yeah, changed actually the trajectory of my OT focus. So Yeah.
And I think that, like, knowing you the way I know you now, I think that you already had some you had a drawing towards the stuff that
Yes.
I teach, but maybe not, a clear direction or a clear, tools and strategies that all come together in like, I kinda pulled a bunch of information together in a very practical way for you to then use.
Yes. Yes, I was able to implement that, and, as you know, yeah, I was able to modify that to my patient caseload, and, but you gave me the beginning of what I needed to make it, functional and practical for my patients. Yes,
Yeah.
definitely 100%.
So, let's talk a little bit. So, whenever I teach a class to professionals, my first approach is to teach it to the professional for their own life. And in our classes, you guys experience that because I have you do every stretch and every
Great.
exercise
Yes.
and on yourself so you can feel what it feels like on your body. So, as we kind of as you started to get introduced to that, how what was that impact for yourself? Like when you started thinking about like how this feels on yourself, was it easy initially for you to separate the two, or were you like thinking patience, or were you thinking self, or was it kind of all blended together?
I think, well, definitely I took a look at it and I said, okay, I need to start doing some work on myself. I'm not as young as I used to be and not as strong as I used to be. And so the one of the big things was posture and really look at my sitting posture and standing, the active sitting and active standing and incorporating that. Even I'll be cooking and I'll be standing at the stovetop. It's like, okay, stick,
Mhm,
engage your core and stand a little more upright. And boy, it just makes a huge difference on my sitting standing tolerance, but also just on the my quality of core engagement.
mhm,
I have purchased the elastic bands, the body elastic bands that you showed us in your course, and when I'm doing those exercises, I really work on involving my core and getting my transverse abdominis engaged, and doing those exercises properly because you can do the exercises, but if you're not doing the core engagement, you really aren't doing the exercises as well as you need to, right? So,
right.
yes, so definitely a heightened awareness of all
Yeah.
that. Even my husband, when I got him a new chair to sit at his computer because his old chair wasn't adequate, and he loves his new chair, and it fits him. He's a bigger guy; he's 6'2", so he needed a bigger chair for his posture. And
Right.
so, yeah, so incorporated that at home and helping him with that. So, yes, it's been
And and do you see the one of the reasons that I do that, well, there's a couple reasons why I really I used to when I did any of my professional courses online, it was required that the people did the individual course first before they could even teach other people. They had to do it for themselves before they did it before. I don't have that strict of a policy anymore, but was really passionate about it early on, and I still am passionate. I just don't control people. Um, is I really feel like when one when we are caregivers of others, and so to be an effective caregiver, we have to take care of ourselves.
great.
We have a finite amount of resources to give, and we need to continue to be making deposits in our own bank so that we have enough to give others. So I love taking care of caregivers. I feel like that is one of my passions of like taking and this starts out as parents taking care of the mom so that they she can take care of the household, taking care of the dad so he can take care of his family, taking care of caregivers. I really means a lot to me. But also, when you feel it in your own body and when you're living it out, it do you see that it's so much easier to explain to another person what you're invested in it, you're living it.
Right.
Would you agree with that?
100%. Even like a simple thing as the belly breathing, which we incorporate into all of our exercises. I do that and I practice it myself. And then as we practice in your courses is doing it, having the patients feel you do it so they can feel me doing the breathing and doing the breath work. It's like, okay, now I get it. And then we do it together side by side, right? So that they get the understanding that you're just aren't telling me what to do. You're doing it, and then I give them an example and I say, I do this every time I come from sit to stand. I make sure I engage my core and make sure that, I'm doing your proper breathing, especially like coming from those rolling stools. You don't have armrests to get up, right? So you need to engage your core, right? And
Right.
so, yeah, just that whole educational and being that I have experienced, I can tell them what I feel so that they can interpret that and hopefully be feeling the same thing. And sometimes it takes, like, I don't get it. I don't get it. It's like, okay, that's okay. Let's do it again. And, maybe I phrase it a little bit different, or I give them a little bit more time. And, most of the time by the end of the session, they're going to get it. And then they're understanding the process.
Yeah.
So going through it with them is important.
Yeah, and I think also us recognize that we didn't get it the first time
Right.
when we're
Yes.
doing it on our able-bodied,
Hmm.
not having a stroke, not having Parkinson's, not being in a wheelchair for 6 months, and we're still struggling to connect with the muscles. So it gives us a sense of compassion and
Yes.
relatability, yeah, I think that that's super important. And I demonstrate a lot. I demonstrate a lot on my body. I show different postures. I have to be able to show the correct thing to expect somebody else to be able to
Right.
do it.
Sure.
But I'm not perfect. You're not perfect. And I think that that's the other thing is like, oh, yeah, I feel this thing happen and then I have to correct it and then I continue. So it's not like this we get to a place and now we've got it all. It's everybody's on a certain journey, right? And sometimes we are more connected or we have more capacity for things than other times, but I think having that base knowledge of knowing how to circle back to it is really helpful. um yeah. So when you so in my courses I send out a series of videos for you guys to watch before you come, right? And part of the reason I do that is to get all of us at like equal playing field, right? Because I go over some anatomy of the abdominals and some, defined diastasis recti and just, some stuff about the transverse abdominis, which I learned next to nothing about in PT school. And I don't know what people have learned and what they haven't. So I give everybody some education coming in, so that we're all in the same place. But I also try to get you guys a little bit primed for what you're going to be learning. When you watch those videos, what resonated? Do you remember back to that? Do you remember those videos and like, did it make you start thinking already about things differently?
Oh, 100%. Yes. Watching the videos was, well, it was very educational, but then again, I am a nerd, but anyhow, it was some basic education. It's like, oh, I want to learn more about that. So it got me very excited. So I did a little bit more research, especially like on the transverse abdominis. Okay. I know we know that, but those words are a little bit foreign because we don't really use them. Okay. So I gained a little bit more education, a little bit knowledge about that going in, but it definitely got me excited. I mean, that's the thing. It's like, oh my gosh, these are great. Okay, I can't wait to learn more. So that's where
Yeah.
it left me with the thing of, ooh, I want to learn more about that. So, and then
Yeah.
you also had the handouts that we had, and those were, and very, very valuable, of course. So it's like, ooh, okay, I can't wait to ask her this question, or okay, what else can we learn here? And so,
Yeah.
yes,
Yeah, great. Yeah, that's exactly why I do that. I don't ever want to assume people know something. I
right.
also don't want to talk down to people that already know stuff, right? So I just feel like that helps us get at and I do this with clients too because we have clients that have maybe done a lot of work or know a lot of stuff and I don't want to assume they know all the stuff, but I just have to always go back to the fact that when I started learning about this, I had been a physical therapist for like almost 15 years at the time. And I felt like I was learning a new language.
Hmm.
Um, I felt like I was learning a whole new, I, it was familiar enough that I could pick it up quick and it made so much sense, but it wasn't like I felt like it was something I should have known from school. Um, and that's my lifelong dream, is to have this as a standard in school. Wouldn't that be great?
That would be
Um,
yeah,
but there's only so much stuff you can learn in school.
right.
Um, and so, I'm trying to make it more standard of care because the core is so important into so many areas. So when we talked a little bit about how it's kind of impacted you personally, and we'll probably talk more about that because you've got some fun things to share in that area. But when you think about how this has impacted how you see clients, can you kind of give our audience an idea of like what you are incorporating with seniors? And with seniors, like, I think it's important for people to acknowledge that you are working with sometimes really debilitated people, right? And I want so many of my clients feel like, oh, is it too late for me because I had my baby 3 years ago? Or is it too late for me because I'm 56? Is it too late for me because I haven't exercised in 30 years? What would you say in that whole, is it too late?
Yeah, it's never too late. Um, yeah, so, my my thought now on the functional core and engagement of that, it starts on my initial evaluation with my patient, and, and just getting them comfortable and really getting them comfortable with me, but getting them comfortable about talking about areas that people don't like to talk about. Being an occupational therapist, I do of course address bowel and bladder, toileting and stuff, and with that engages the core, right? So some really basic questions for my patients on initial eval is going more in depth about bowel and bladder and bowel and bladder control. Are you getting to the bathroom on time? What are the problems that you're having? Um, but even further back from that, starting with a wheelchair eval and posture and proper posture and sitting, because boy, I tell you, just the wheelchairs and the sag that you have in a wheelchair and patients sitting in those chairs and they're sitting and they're slumped and they're on oxygen and they're not breathing well. Okay, if we put a solid seat insert into this wheelchair, that's going to get their hips in better alignment. If we give them a lumbar support or some, now we've got them sitting more upright. What quality of life can we give them? They're going to be able to swallow better. They're going to be able to breathe better. They're going to be able to talk better. It just it goes on and on forever, right? So initial eval, and my initial eval, we there's a lot of give and take with my patient, and I'm asking them a lot of questions, and I'm getting some really nice information so that I can then write up my treatment plans and
Yeah.
I'll tell the patient this is what I would like to work on with you. And most of the time, when I say I'd like to work on your posture and your toileting, patients are like, "Oh, that would be great," because it's a
Okay.
that we don't talk about. As you
It's a
know,
desperate need. It's an obvious need. Like, I always tell people, like, when we start talking about this stuff, I was like, if you live in or work in a skilled nursing facility, it is not a secret that most of the clients have poor posture and have bowel and bladder problems. This isn't
yep,
a secret. We don't
right,
have to pretend it's not happening. Let's address it.
yes,
Yeah.
yes, yes,
Yeah.
and and even educating the family members that this is something that why are they why is it this way? How can we help? And what's our treatment plan? And so
Yeah.
going forward with that, yes, yeah,
Yeah. Yep. And one thing that I say a lot in the class, and I think I've said a few times on the podcast, is um better is better. Sometimes we are fixated on things being completely healed and completely 100% better. And in some of my clients, I absolutely can get there. But in some of our clients at the end of their life, as things are declining, we might not get 100% better. Somebody with Parkinson that has a degenerative disease, somebody with MS that is declining, somebody that's had stroke, somebody that's in their 90s. There's certain things that our body starts to wear out. But that does not mean that we can't get people 50 or 75% better. And I tell you that if we're just looking at either they're continent or they're incontinent, and those are the only two options, that is not doing anybody service? What if they are incontinent, but they're only incontinent once a day versus incontinent every single time they have to go to the bathroom? The
Right.
difference in quality of life, burden of care, lifestyle, enjoyment, everything is dramatic in those two scenarios. So I think that that's the other thing is better is better. Any amount of better. And in when you are struggling and when your core is weak, your pelvic floor is weak, your posture is poor, every amount of better is valuable, you know? And
100%.
and I think that that helps us to shift, okay, we have a treatment plan and our goal is to get things better, And so when you're seeing your clients, um, can you share with the audience kind of just maybe like the range of type of clients that you're seeing so they have an idea of how applicable this is to a lot of different because most of yours is are people that are residents, right? They're inpatients
No, actually, well, yes, it's
and
inpatients. No, they're all inpatients, and so the average stay is anywhere from 2 weeks to say 8 weeks is the
okay.
average stay, and age is anywhere from 65 to 102.
Their
So
goal is to go home usually.
their goal is usually to go home, a return to their prior level of care. So, or residence. So that might be an assisted living, it might be memory care, sort of depending on where they were. But their goal is not to stay in our facility. Correct? They leave our facility. Anywhere from I have a young gal right now. She's a back patient. She's actually awaiting back surgery, so she's in our facility because of so much pain. And I'm really working on core and all that engagement prior to her surgery because
Oh,
we
good.
know what's going to happen with the back surgery is she's going to be weak and everything else. So we're building up what we can to get her to tolerate this surgery that she's going to have. I have my hip patients. I have my 75-year-old hip lady who she fell going to the grocery store and she was independent with everything. So working with her on this, or my 102-year-old woman who fell out of bed and she's bedbound. She was bedbound prior. She's bedbound now. Okay, so
Mhm.
how can we work on her bed mobility? How can we work on these? So I have my range of patients is you name
Yeah,
it, we see it. Yeah, yes.
yeah,
But
yeah.
but all of them, even my higher level, I have my higher level people who they came in because they had a fall, they didn't do any injury, but they need to rehab because they're weak. You go from sitting to do these core exercises that we're doing with the elastic band and integrating the proper breathing technique. Do I have them standing? And now they're doing these exercises and standing, they're engaging the core and just the educational basis of okay, postural balance, postural control. How do we do this? How do we engage your core into all these activities?
Yeah, yeah. And, it's probably hard to think back to how you were seeing your clients before, because I have no doubt that you were an excellent OT before you had this information. But it must I can you look back to, like, how you approached all the things you're talking about now prior and how you approach it now. You mentioned how this kind of was a paradigm shift. And like the overall feeling of success with your clients and it may be in little things like in quality things, right? But
Right.
can you talk about that a little?
I think the biggest thing is the documentation of it and having it be saying, okay, this is, I used to say I did instructed patient on proper body mechanics for getting out of bed. Okay, that would before. Now I can say instructed patient on core engagement and trunk elongation when getting out of bed to allow patient to have, and so my wording is definitely a lot more professional and it's just more backed up with scientific data. It's like, okay, and then that might even be a goal, but then the next one would be working with patient in standing, working on postural alignment and core engagement, doing oral care to allow person to stand at the sink for 15 minutes, not 15, that's a long time, 5 minutes during task, right? And it
Great.
just has so much more quality. My wording is better, my quality is better. It's like okay, look like, they know what they're doing. Instead, a patient stood at the sink for 5 minutes with fair balance. Well,
Yeah. Yeah.
there's a
And
huge
when
difference between those
anybody
two.
that's seen that client with you also knows what you were working on, right?
Exactly,
Um,
right.
and
Yes.
when the insurance is reviewing that person, it's clear that this is a skilled care. Like
Yes.
this required a skill of a therapist to do, not just anybody is standing with them, not just their husband
Right.
standing there with
Yes.
them, that there's a reason of what we're doing. But also, I think even that documentation process, and we talk about this in our trainings, that documentation process helps us to remember our goals, like
Yes. Yep.
what we're shooting for. Because it's easy, like we are very goal, like therapists are very goal focused, but it's easy to kind of lose sight when there's a lot of moving parts, to like what is gonna build on the next thing,
Right.
and people that have worked with me for themselves, know, like, okay, we start in sitting, we start with the breathing, then we start with some out without back support, and then in standing, then we work on releasing, we work on doing stuff like when we're, exercising, and there's like this progression of things, right? And I think that that's the same thing in everything that we do as therapists, looking at, okay, we're starting here with our goal to get here. Um, yeah, that's fun to see. Can you share a little bit? We just did a class together. You did our advanced class, and in the advanced class, there's a lot of expectation of you becoming a teacher, right? And
Yes.
you are already a natural teacher. You're teaching your clients all the time. You teach students all the time. You're a leader in your facility. But I really ask you to step it up in the advanced course to become, a master of this information for your team. And part of that is sharing with other therapists and nurses and other people in your facility. How has that been going for you?
It's great. I love it. We had the opportunity. We had four physical therapy students at the time when I was doing the training within our facility, and it was so fun because, of course, they're natural learners right now because they're just absorbing everything you tell them. And I did two that was really substantial for these kids that they get students.
Mhm.
Was the breathing, engaging the breathing, and abdominal splinting. And I
Yeah.
tell you, boy, and it was so fun to hear them after, like, even the day after I did the training, and they're talking to their patients, like, okay, so you want to do belly breathing. This is what you're going to do. Now, I want you to engage your core when you come from sit to stand. It's like, yes, and it was, it
Yeah.
was, it was wonderful. And
Yeah.
the wheelchair positioning, and then they'd come in and say, "Oh, Mary, I forgot their leg rest. Don't worry, I'll go get them." Because I had shown them proper wheelchair position, and this is what you want them looking like. Oh no, but they're not right because look at their knees are too low, and it's like, okay, go get them, and then I put them on. Is this right? And it's like, great. So just being able to impart that knowledge on that staff, and then even my the director of nursing and assistant director of nursing, they were all in. And then I went into their office one day, and they're both sitting, and posture was terrible. And I walk in the door, they're like, oh, they sit up nice and tall, and they said, watch out, Mary's here. So it's sort of
Yeah.
fun, right? It's sort of fun to
Yeah.
be that. Okay, that's good. It's fine to be known as as they say, the posture police, right? And here comes
Yeah.
Mary. My patients will say, "Here comes Mary. I better stand up tall." And so, but
Yep.
that's okay. It's a good thing to be known as. Yeah.
Yeah, it is. I mean, whatever triggers people to use that, and sometimes, like, I will tell people I don't even use the word posture when I initially am assessing somebody, because as soon as you say posture, people are like, "Oh, get my
Right.
posture," right?
Yeah.
But yeah, and then once people, yeah, come to see me, they immediately like, "Oh, I'm in front of the teacher. I have to be."
Right.
I'm like, I need to be watching you all the time, so you've got that posture.
But
Um,
on that topic, you said on our first training is you said the evaluation starts the minute the patient walks in the clinic. And so
yeah.
my evaluation starts the minute I walk in my patient's room,
Mhm.
because how they're lying in the bed, how they're feeding themselves, it all starts as soon as I say I'm from therapy, then things
It changes.
change, right? So I do a little watch. I stand outside their door and I'm on my computer and I'm doing a little, but I'm watching them and just seeing what, and then they kind of know that too, that I watch them all the time. It's like, watch out, she's watching me. But you have to, because what they're
It's
doing
what
in their,
Yeah, we're not looking at a moment in time.
right.
We're looking at all of the time, and it doesn't mean you have to be perfect all the time, but whatever you're doing the most
Yes,
wins. So it
exactly.
can't
Right.
be what you're doing on in front of the teacher.
Right. It's not that 45 minutes that you're in therapy. It's what you're doing when you're sitting in the dining room playing bingo. How
Yes.
is your posture? What are you looking like? Yes.
Yeah.
Yeah.
Yeah. Yeah. I love that. I love that. So share a little bit also. So in this advanced class, we taught you guys some additional stuff, and I had you be kind of a guinea pig and assistant with me, and you chose to do a case study on yourself. I would love for you to share a little bit about that, and it's going to introduce some information that we haven't talked about here on the Tummy Team podcast yet, so that's
Right.
okay. So
Okay.
go ahead,
Do,
and
do you
I'll
want to
chip in.
do you want to give a little background on the TTNS on that one?
Okay, I will. All right,
Okay.
so one of the tools that we are that I use with some clients, and that I teach in these classes is a concept called TTNS, which is transcutaneous tibial nerve stimulation, and it uses a TENS unit to provide or to yeah, to provide like a neurostimulation to the tibial nerve down at the ankle, and that tibial nerve runs up to the sacrum and up to the nerve root that it shares the same nerve root as the bowel and bladder. And there's a tremendous amount of research on how using this it's called neuromodulation, using these nerve kind of this sensation to the nerve, stimulating this nerve can help with specific bowel and bladder issues that are related to sensation and sensory feedback. And one of those things is urgency, the desire or the thought that you have to go to the bathroom really quickly, that sometimes can turn into urge incontinence where you've got to go and you can't hold it and you leak before you get to the bathroom. So urgency has to do part of the problem with urgency is a miscommunication between the bladder and the brain. The bladder is telling the brain, I got to go and I got to go now, even when they maybe just went, or maybe when they went 30 minutes ago, or maybe they haven't drank that much. It's an overreaction, or the bladder doesn't say anything until it's really full and it's an overreaction. So the neural feedback between the brain and the bladder is disrupted or dysfunctional. And I'm really simplifying it, but what this neural stimulation does is it starts to normalize the sensory feedback to our bladder, which can be really valuable to a large number of population. And it's something we introduce in the advanced class, and it's something that I do with some clients, actually more and more clients. And so this was one of the things that I introduced to Mary, and Mary, take it away. How
Sure.
did you
Okay.
get that
Yeah. So
information?
I saw this information. I said, wow, that looked pretty fascinating. And I said, well, I'm a little older now, and I was having urgency of having to go to the bathroom, oh boy, up to 9 times a day. And to the point where I wasn't wearing scrub pants that had a tie, because sometimes I had to go so quickly that, I wasn't sure I was going to get my scrub pants untied in order to get to the bathroom. And then also I had Nocturia, which I was up to 4 times a night to go to the bathroom, which is a lot. That really disrupts my sleep. So I said, you know what? Why don't I try this? So I'm already doing some functional core exercises, and I'm going to incorporate functional core exercises and use of the TTNS. I said, why not? What's it going to hurt? So I did it. I had 22 sessions. So I did it about 5 to 6 times a week, 30 minutes of the stimulation. And then I did my core exercises about 5 to 6 times a week, about 45 minutes. And the results were pretty phenomenal, I think. So I went from 9 times of urgency during the day to no urgency. Well, no, that's not true. Maybe once every week or so that it's like, oh my gosh, I got to go to the bathroom, but no leakage. And having to urinate from 9 times a day to about 5 to 6, and having to get up at nighttime to go to the bathroom, reduced from 4 times to 0 times to one a night. So I
That's
found that
significant.
pretty fascinating. So it's like, wow, that was it was a great study, and I'm glad I had the opportunity to do it because it fixed my problem. But I still do it. I'm still doing it now about 3 times a week. The
Okay. Yeah.
the TTNS, and I'm doing my exercises, 4 to 5 times a week. So yeah.
And
So
so when you think about, like, I mean, we have to pee. Like, I don't know if most people count how many times they pee a day, but 9 times a day is quite a few times, right?
lot.
It's quite a bit. And so from going to 9 down to 5 or 6, that is a significant change. And but what's even more powerful is that nighttime,
Yes. Oh
because
boy.
nighttime urination need disrupts your sleep, and
Yes.
it actually becomes like that. It actually causes more of the problem, because when we sleep and we get into a REM sleep, our body releases um, chemicals, hormones that actually slow down urine production so that we can sleep longer without having to pee. But if we're having to get up over and over and we never get into that REM cycle, we actually are continuing to produce the same amount of urine all night, and have the urgency. So then it's just an ongoing cycle
Yep.
of torment.
Yes.
Um, yeah, and so you know, being able to address it and doing something that is pretty passive, you know,
Yeah. I mean,
pretty.
you plug
All
it
you
in
have
when
to do
you're
is
watching
download.
TV, right?
Yep,
Yeah.
you just put it on while you're watching a show or answering your emails, or,
Hmm.
that kind of thing, drinking your coffee, doing your Bible study in the morning, you
Right.
know, that's like you put it on, and it really goes to show that our bladder is a muscle that's trainable and that has a neural feedback thing. One of the jokes that I made that I now have been saying a ton is like how we are the boss of our bladder, and we can be the boss of our bladder, um, but we have to have some resources in place. And when we have been responding inappropriately to the signals from our bladder, or there's certain things that are irritating our bladder and making us feel that urge more, and then we feed into it, there's a cycle that happens that can be really detrimental. And
Yeah.
then it gets to the point where it really does get worse and worse, because it becomes like some urgent continence. It starts there, and then we start wearing a pad, or in our client's case, maybe briefs, and then it's just kind of like it becomes such a burden of care on the providers and the staff, that they don't always get there in time. So then the clients get to the point where they just go, and now they've lost the capacity to identify when they need to go and when can hold it.
Right.
And now the bladder's the boss. And and there is a way back from there. There is a way back from there, but it is hard once you get down that far. It's hard to circle back. The cool thing about TTNS is it starts at the neurological level that gives us a jump start with all the other stuff that we're doing. So
Yeah.
you can start to see that success. And that's really fun. It was really fun to hear you share that case study in the class. And she shared it really in a fun way, where she wasn't sharing that it was her at first. And then when she shared that it was her, everybody was like, "Oh my goodness," but it was it was really cool to kind of see, like, taking that objective measure of where was I when I started and where am I now? Because it could be easy to say, like, "Oh, I'm still getting up once a night." Well, once a night versus 4 times a night is
Yeah.
completely different, right?
Wonderful. Yes,
Yeah.
definitely. Yes.
So I love that. I'm sure I'm gonna get lots of questions about TTNS now.
Yeah.
Um, but
That's good.
that's okay. That's okay. I feel like at some point I need to do a podcast just on urgency and urgent continence, because I feel like that I've learned so much about that in the past 3 years that, yeah, that's been really eye-opening. And also not just in, our senior population, but like also like I shared this story the other day with another class that I was teaching, but like there's certain things that irritate your bladder, like alcohol, tea, coffee. I notice that when I teach a class, I'm usually drinking green tea because it kind of gives me a little bit of a pep, but it also irritates my bladder. So I feel like I have to go to the bathroom all the time. Uh, and I was on vacation, and I had gone out to dinner, and I had a cocktail, and I went to the bathroom after we left, and then we were in DC, so we were on those little scooters that you can scoot around town, and we got on the scooters and we scooted all the way down to this wharf waterfront area. And as soon as I got there, I felt like I needed to pee again, and I know I had just paid 10 minutes ago, and I hadn't had anything else to drink, and I was like, but in my immediately I was like, where's there a public bathroom down here? And then I was like, I can't see any public bathrooms. I think we're not going to be able to stay here very long because we're going to have to get back to our Airbnb, because I could feel myself getting anxious that I was going to need to pee. And then I just had this moment like, I am the boss of my bladder.
Right.
I know, one, that there's nothing new in there. Two, I went 10 minutes ago, and I know I can go 3 to 4 hours without peeing. Right. And so I took a couple belly breaths,
Mhm.
and then I did a couple of pelvic floor lifts to kind of squeeze. It calmed down my bladder. My bladder was starting to have spasms because it was irritated. I calmed down my bladder, and then paid attention to where we were at and what we were doing. I just diverted my mind from it. I didn't fixate on it. We spent an hour down on the wharf. Then we took a 20-minute um, like Uber back to our Airbnb. And then when I got there, my husband's like, "Don't you need to go to the bathroom?" And I was like, I don't think I do. You know,
Yeah.
and then maybe 20, 30 minutes later, I went to the bathroom, but I kind of stopped that urgency cycle by just recognizing what was going on. And I knew that alcohol is an irritant. Panic doesn't help.
Right. Yeah.
Anxiety doesn't help. Right?
Definitely.
So I just used a lot of the tools that we teach people, and it works even on, I don't have a lot of urgency and incontinence issues, but every once in a while I like have this like I gotta go, right? And I had another client saying the other day, I wonder if like, with kids that like feel like they need to go right away. Like if we are teaching them, and it's not like I want people to hold their urine forever. That's not what we're talking about. But there is a certain amount of what is the capacity of my bladder? And I need to ask it to function at its capacity so that I have that capacity, you
Right.
know?
Sure.
So anyway, I feel like it's interesting information for everybody, right?
I agree. Definitely.
Okay. All right. So, I mean, there's so many cool things that you're doing within your work that I know that you're doing. Um, but I would say like, and maybe we might need to do another podcast talking about some of that stuff too, because I think that's really interesting. But overall, with all the stuff you've learned now, if there was something that you wish you had learned sooner for yourself, for your clients, as a professional, can you think of like what do you wish you had known sooner?
I think the basis, the whole basic point is just the belly breathing and the core engagement, because you can stem so much off of that. I wish I would have known the proper techniques for that, and teaching my patients that, because that can build your whole treatment program. So I think that's huge, huge.
It,
Um,
I agree, and it's funny how often I have clients that have been doing all kinds of crazy stuff, and I have them sit, breathe, and rub their tummy, and they're like, "Really? Is this gonna work?" And I'm like, "Don't underestimate that breathing."
right.
Yeah.
Yes. Yes. And I think the use of abdominal splinting too, because I have found even my patients who have, they say it's my back injury, it's my back injury, and they've got a big pot belly, and their posture's horrible, and it's like, okay, we're going to try this. I'm going to show you this abdominal splint. And I put it on the patient, and it's like, oh, my back is better. I said, yeah, your back is better, but what else is happening? Oh, I have to engage my core because I have this splint on. And so that's such a wonderful tool to bring it all together, right? Because they have to, like you said, they have to touch, they have to feel their core to put that belt on, right? That binder on. And it's like, oh, okay. And then, well, I think I needed a little tighter. Well, no, tighter's not always better, but that it gives them a really nice feedback, especially from my patients who can't feel it without a little bit of more feedback. And then you take it off when they don't need it, or, you do it less. But I think those abdominal binders have been fabulous.
Yeah. And it's not, a lot of therapists are like, oh, it's a crutch. I was like,
No,
PTs prescribe crutches all the time because sometimes we need a crutch. It's
right,
not forever. It is a tool that actually helps you feel a muscle that you have neglected for a really
right.
long time.
Yes. Yeah.
And you can't heal what you cannot feel. And so that feedback, and you can't stay there with their hand on them all day long. You've got other
Right.
clients to see,
Yes. Yes.
right? So in that whole wrap around from the back, all around the sides to the front, them really getting the idea of what that transverse is, what that core muscle is just so there's nothing like it. And I will see it in their eyes. And I don't know if you've noticed this, you put it on where they're like, oh, there I
Yeah.
am. You
Yes.
know?
Right. Yeah. And it's calming too. It's like a nice hug. It's a nice hug that stays around you for a while, right? And yeah, it's that nice input. Yeah.
Yes.
Definitely.
I love that. I love that. Okay. All right. We're going to wrap up. Thank you so much for being here. Is there anything else that you would like to share with our audience before? I know you probably have a lot, but anything else you can by sharing as we wrap up?
I think just a big thank you to you, because you changed my OT focus, a lot of my OT focus, and just being able to implement this, I've definitely been able to increase the quality of my patients' lives with doing the functional core and pelvic floor training. So
Yeah.
thank you.
Yay.
Yeah.
I love hearing that. I love doing this work. Obviously, everybody that has met me know I'm pretty passionate about it, but I love the teaching even more because in every class I'm at, there's like 30 to 50 people that see, 5 to 8 patients a day.
Right.
The the multiplication of getting this information out to more and more people, and especially an underserved population like our seniors, it makes me very happy. So thank you so much for the work you're doing and how willing you are to share it with others, with new students, with patients, with your family members, with me, with our audience. I really appreciate you, Mary. So thank
Okay.
you.
Thank you.
All right. All
Right.
right, guys. If you want to know more about what we do here at the Tummy Team, please look at what we do. If you work for an organization that needs training, you can look at Real Life Rehab, and I set up custom CEU courses for facilities and organizations, and I'd be happy to do that for you. So, okay, everybody, I'll see you next time. Thanks, Mary.
Thank you. Bye.
Once again, thank you for joining us at the Tummy Team Journey. We would love to help you restore your core and be strong for the life you were meant to live. You can get more practical strategies at thetummyteam.com, and we'll see you next time.